Welcome to the Center Collaborative, Creative Solutions in Behavioral Health and Criminal Justice, brought to you by the Oregon Center on Behavioral Health and Justice Integration, which is also known as the Center. We at the Center are all about solutions. Our job in Oregon is to facilitate improvement of the system so behavioral health and criminal justice can work better together to engage people in treatment while promoting public safety. I am your host, Chris Thomas. I hold a master's degree in clinical psychology and have focused on the intersection between behavioral health and criminal justice for 20 years. Over 7 of those years were behind the walls of a maximum security prison. During this podcast, you will have the opportunity to sit in on real, in-depth conversations with experts about complex topics in a way that is both fascinating and digestible. We will focus not just on what is wrong with the system, but what is going right and how we can work together to evolve. This podcast is a conversation in a series of conversations where we touch on people's legal rights and their options related to seeking medical care. Since our conversations are intended for informational and educational purposes only, they are not a substitute for or a reason to delay seeking professional legal or medical advice. On today's episode, I have the chance to sit down with Chris Bouneff, Executive Director of the Oregon chapter on the National Alliance on Mental Illness, NAMI, to talk about what does NAMI do, the examples of education NAMI provides free of charge. We discuss NAMI's current proposal for a bill in the short session focusing on addressing the wage gap for those working in the behavioral health field. We also discuss why we need to focus closing the wage gap and providing more services at the same time instead of doing one after the other. We talk about how guidelines and standardization can be incorporated into behavioral health to support service availability throughout Oregon for consumers. We discuss NAMI's partnership with Crisis Intervention Teams, CIT, and how to contact NAMI. I so enjoyed my conversation with Chris. I think you will too. Welcome to our conversation. We're really excited to have you here with us today, Chris. Welcome to the podcast.
Thank you for having me.
We're thrilled to have you with us. And what I think the listeners would really like to hear first is, what does NAMI do?
Sure. NAMI, as the name befits, we're part of a national organization, and each state has a state organization. And then under each state organization, there are what we call affiliates or local chapters. And at the heart of what we do is free programming, education classes, and structured support groups and other types of workshops and seminars, basically for any component of a family being loosely designed. So if you live with a mental illness, if you're a parent raising a child with a mental illness, if you are a teacher working in schools, whatever sort of these community structures and family structures are, we have free education courses for you. We have free support groups for you, again, all based on lived experience. So when you take a program from us, it's taught or facilitated by people with the direct lived experience that you're coming to the program with. And it's through that programming that we fill really these giant gaps within our treatment and support system, which is trying to educate how to get through it, how to find treatment, how to find help, how to find supports, how to not feel alone, how to address this in other community settings when we see it. And that's the major gaps we do. It's through that curriculum and, again, these seminars and workshops and specialized things for employers that we serve approximately 14,000 Oregonians. We also run what we call a resource helpline through our state office and the chapters. And that's people calling and emailing with a very common question that we get, which is, I'm going through this, my loved one's going through this, my child's going through this. What the heck do I do? Where do I go? And we help them navigate through those questions.
So NAMI does a lot of really important things. You do a lot of education, it sounds like, for folks who are working with folks who have lived experience. And then you also provide support and guidance for folks who are living with that and are looking for help on having to navigate the system.
Yeah. And I think it's important to understand lived experience. This is the broadest sense of the word. So someone like myself lives with a mental health disorder. So I bring that lived experience. I'm also a parent who has raised and is raising children who have behavioral health disorders. So there's that lived experience. And so it's more often in our system, particularly our public funded system, when we use the term lived experience, we isolate it to somebody living with serious mental illness. And within NAMI, we're constantly trying to remind ourselves, like any kind of healthcare condition, this affects more than just the individual living with that disorder. And it's contingent upon us working with that system around that family or the individual, because that's the whole support network. And so to be healthy, you have to engage an entire structure. And each part of that structure brings a lived experience, or in the case of many of us, we tick multiple boxes. So we have multiple lived experiences. And so it's us with that lived experience, bringing it to bear through specialized training to teach other people and support other people who are going through the things that we went through.
That's such a good reminder, Chris, that it isn't just about the person who is currently working through and dealing with the symptomology, but also the broader support system and the folks that love them and are trying to support them through the experience as well. It's not just about the one person. That's such a great reminder.
Well, and it's really, think about it. What other healthcare condition would you only work with the person living with the condition?
Right?
Everything else that is good health. One of the things that frustrates me about the system is we don't teach family members to be supportive of their loved one, whether it's their child, and we can't forget children because that's where onset happens, or it's an adult, someone who has churned through the system. Families are ill-equipped to support their loved one in a productive manner. And so within our organization, we take pride in being able to work with an entire structure, whatever family or support, however that's defined for the people impacted. But it's supremely important that we work with those structures, including the community structures. So in the case of children, teachers and counselors and anybody who is there to support a person or family going through this.
What absolutely important work on so many levels. And speaking of the work, I know that you and I wanted to talk about some of the initiatives that NAMI has been working on. You've got some bills that are coming up in the short session that you wanted to talk about today. And do we want to talk about the workforce crisis?
I think we have to, because 2021 has been an unusual year in that we thought we were getting out of 2020. And in the early part of 2021, we went through a legislative session. We had policy bills. We talked about budgets. We did some wonderful stuff, all with an eye towards somewhere during the summer, we might return to some semblance of what normal looked like before the pandemic. And it became clear somewhere in the summer with the Delta variant, with the national discord over how you even respond to a pandemic, to the completely changing labor market that changed in a matter of really months, that our workforce became an issue across the board, the great resignation and that kind of stuff. For our workforce, particularly in the publicly funded system, it became even a greater crisis because that workforce has always experienced a wage gap. They have always been underpaid compared to, say, a warehouse forklift driver or some kind of retail position, right? So in our publicly funded system, people work there almost because of altruistic values more so than the compensation that they received. And we all knew that was a problem, but then that wage gap within a matter of months grew. So where retail establishment went from paying $17 an hour to $22 an hour, our publicly funded system was stuck at $17 an hour and couldn't increase that. So that's a long prelude into this, is that we are in such a crisis right now around workforce that if we don't address that, we won't be able to address anything else. We could probably all agree that we need some major reforms, even though we don't agree on what those reforms may look like. But you can never even consider those reforms if you don't have anybody there to do the work. And that's the level of crisis we're actually at with our workforce.
The other part I think of when I think about the work gap is that not only are the wages low, but also the education that is required to be in those jobs for our behavioral health workers, and then also the stress and the cumulative effects of trauma for those workers as well. So there's the wage gap, and then also, even if you're going into it with the most altruistic means, it's difficult work.
It's hard work. You're right. Education is a huge requirement and a necessary requirement. And what wages never did was reflect what we were asking of that workforce, both the preparation of that workforce and the roles they were fulfilling. I would also argue we were putting more stress on that workforce because we weren't doing the things that were necessary to prevent people from reaching to the level of acuity that they were causing that workforce significant stress. So you put that all together, and yeah, we had a workforce crisis in a sense before that. But the gap and all those factors, there was just proximity enough to the market generally that we held on long enough. We used the salve of, oh, we have time to fix this because it's not so bad. That changed. So you have a huge wage gap. You're right. You need a well-prepared workforce. Our solutions in the past were usually to decrease the requirements that people to enter that workforce versus actually compensating people to the level that was commensurate with the training and experience and the work that they were doing. And that won't work anymore.
Mm-hmm.
So you can't just eliminate that you need a master's degree or need to be a licensed clinician, for example, to do certain work within our system. You can't race to the bottom in this kind of labor market. And that's usually been our response. And what the response needs to be and what we're looking for in a short session is a response that actually brings wages up, not only to a competitive level in the labor market by large, but also to a level that, again, is commensurate with what that workforce is asked to do, the preparation educationally they're asked to do, and the ongoing training, frankly, that is necessary for them to do the quality work that those populations actually deserve to receive that type of quality service.
This is a great intro into the work that y'all are working with the short session and the upcoming bills that are being proposed. So can you talk a little bit more about the solutions that NAMI is helping support in the short session?
Yeah, so NAMI in Oregon, I've always feel really fortunate being in the state I am. We're a small state. Knowing people is important and easy to do. Also, NAMI feels like a Switzerland in our system. We don't have a financial stake in Medicaid, for example. We don't bill for our service. We give our stuff away for free, which is not a great business model. I mean, we're really highly dependent on charitable giving and support from other entities. But because of that, when I get on the phone or send an email saying, hey, we need to think through this problem, would you please come give us your time and your expertise? People do. What we wanted to tackle this question about compensation from the idea of what should we be doing?
Mm-hmm.
What is it going to take so that a provider can actually be fully staffed so that the children's beds, residential beds they have are fully open? We saw all these competing letters going out from all these different systems, and it was fairly consistent messaging around compensation, but the solutions were all over the map. And we brought a giant group of people together to meet. And it really came down to what would it actually take to get money directly to providers in our publicly funded system across the lifespan. So it had to be, we've been focusing a lot on kids providers, but we can't just infuse cash into kids providers because they're going to poach workforce from the adult providers, for example. So we can't put systems at a competitive disadvantage to each other. And we came up with what we thought was a pretty novel solution that has a history of success, which is a paycheck protection style program run by the state that would go directly to behavioral health providers in a grant format to run directly through their payroll. Whereas the federal program was about retention of FTE. What we're advocating for is the state program is actually about getting wages up and doing it for a duration long enough, because the huge issue hanging out there is you can infuse providers with money, you can raise wages, but if you don't solve the compensation issue, the rate issue, the reimbursement issue, if you don't get reimbursements closer to the cost of care, we'll come falling back to earth and crash and burn. And so there's some really hard work to be done. But what our contention was that we need to buy time for 18 to 24 months to really address the workforce issue now, get wages up now, and gamble that we as a state can solve over the next 24 months that reimbursement issue. And that's the bill you're going to see in the short session. Representative Rob Nose and others will be promoting that legislation. We're trying to get dollar figures behind that legislation, but it really is getting providers money now, getting it into their payroll now, so not going through a third party, and buying us time, recognizing this is a gamble, but we have to take this gamble to solve the reimbursement issue long term.
Representative Noyce was behind a lot of legislation that was really helpful for behavioral health last session, a lot of investment. And so I could see where he would be very invested in making sure that there was workforce that could carry out those investments.
Yeah, but Representative Nose, chair of the House Behavioral Health Committee, Tana Sanchez, Senator Kate Lieber on the Senate side. It's been really helpful that the House has retained a committee exclusively focused on behavioral health. And that gives you a nexus point to really get into more substantive policy and budget discussions, where if it's done in a general healthcare committee setting, the expertise around that, you have some expertise, but the depth really isn't there. And so if you look at the House Behavioral Healthcare Committee and the leadership there on both sides of the aisle, you find people who can dive down into these type of things. Both the legislation that came out of last session and the legislation we're talking about now, these are not easy things to cast into law and actually describe and promote and explain. And so that's been helpful to have people like Rob Nose, Tana Sanchez, Representative Morgan out of Grants Pass, have that level of expertise and bring it to the table.
Moving more into a nuanced system, nuanced changes, like you and I were talking about earlier before we started recording, around instead of just continuing to invest in the system that we have and calling that good, but also looking at what can we do differently? What gaps are there? How do we fill those gaps differently? What aren't we doing that we need to be doing in the future to have a robust continuum of care versus the alpha and omega of options?
Yeah, so our contention would be, and this puts us at odds with some entities in the system. So the world changed when the Affordable Care Act was passed. We were able to expand Medicaid. We were able to cover people with commercial products that had benefits. Prior to that, the world was bifurcated, trifurcated, silos all over the place because we had tens of thousands of Oregonians with significant need who never had coverage. So we just threw some state general funding at the problem and said, hey, you guys go out in counties, do the best you can. You're in charge of everything because we can't find this anywhere in the healthcare system because the healthcare system has been allowed to abdicate its role in all these areas. So you're in charge of everything. We're going to give you a little bit of money knowing that this is really not going to serve many people and you just do the best you can. We expanded Medicaid. We covered more people. We've pursued really more aggressive parity requirements across the board in health insurance coverage. We've never come back to that crux of the issue of who should do what. How should that be funded and what should that funding be? And so we still have this really siloed system and people who are responsible for the same things, but still poorly funded to do those things. And I think long term, as we hopefully emerge from the crisis we're in now, that's a question that if Oregon is ever going to take a giant leap forward, has to confront. What is the structure of these things? And that's not to cut people out of the picture or cut entities out of the picture, but it is to have a more thoughtful discussion about who's supposed to do what and what is that, what should that what be and when should that come to bear? When is someone, for example, considered serious mental illness with a chronic condition that needs long-term engagement and all these things? And when does somebody really need that episodic care that gets them through a period of time, that gets them onto a pathway where maybe their use of services and supports is minimal in comparison to what they just utilized?
And how do we, for folks that are in the episodic piece of it, how can we engage and be in services and have the services provided so it doesn't end up later on being more of a chronic crisis nature?
Yeah, and that's a good question. I think that comes back to these all other policy pieces that NAMI has been pursuing, which is around stronger parity requirements, making sure that people get what they need at the time they present that need. And that even there is sometimes a complex conversation because NAMI is interested in pursuing more standardization. You still have this bias. Don't tell us what to do. We're all going to sit down in our community because our community is unique and we're going to figure out what we need and how to do it. And our contention is we don't do that anywhere else in healthcare. Why would we do that? So let's take the things we know that work. Let's take the tools we know that work. Let's use an ASAM, for example, for addiction medicine. Let's use LOCUS for level of placement decisions around adults. Let's use the COW LOCUS when we're talking about the unique needs of kids and adolescents. Let's use those as the basis of determining what medical necessity is. Make sure then the pressure is there to provide those services. Consequently have the financial pressure to finance those services so that it's not just the expectation on the community to have those services. We're actually infusing enough money to ensure those services are there.
That's
and get
a big part of it.
Yeah, but you can't do that in a system that is loosey-goosey. Our system, and again, this is really painting with a broad brush. And when you paint with a broad brush, it's very dangerous. Nevertheless, one county is not so unique that it can't learn or partner with another county. One health system isn't so unique in one area that another health system can't do the same thing and bring the same services. Our state is not so geographically diverse that we need a completely different suite of services and way to be eligible for services in one part of the state, but have something completely different in another part of the state. Ultimately, that's where we have to push our system. We fight against the medical model, and justly so, right? Our services should be unique to us. They should meet the underlying need that we present with. We're not bringing care for diabetes into behavioral health, right? That's not the application to the medical model. But when you look at the medical surgical world, what they are about is understanding what are the best practices, what are evidence-based, making sure that to the degree possible, understanding variation among regions based on geography, population, economics, these various things, but making sure there's a baseline construction of services there on the medical surgical side. And that's sort of the next frontier. I shouldn't even say sort. That is, I think, the next frontier for behavioral health is getting to that level.
So when I'm listening to you, Chris, what it makes me think of is there should be, regardless of where you are in Oregon, if you're experiencing condition X, you should have the suite of services available to you regardless of where you are in Oregon. It may look different if you're in the metro core than if you are in frontier Oregon. There may be slight nuances in how that has to be done a little bit differently because it's not in the metro core. But there need to be guidelines and there needs to be funding and having things actually available where you don't have to move to the metro core in order to get your services met. Is that what I'm hearing?
Yeah, let's take a typical family that we deal with, a teenager who has gone to the emergency department in crisis anywhere in the state, even the metro core. And the totality of the assessment at that level is some kind of brief assessment to determine need. And then what usually happens is either you're parked at the emergency department because there's nowhere to go, or you're sent home because there's nowhere to go.
Mm-hmm.
And our contention would be, we have diagnostic instruments like the Cal Locus, for example, that really could come to bear to say, this is what this family needs. This is what this young adult, this teenager needs. And then if they need, say, residential care, what the variation may be is if you're in the Portland metropolitan area, for example, that may be right there in your community.
Mm-hmm.
And we need to have enough of that capacity there. If you're in frontier Oregon, maybe that's a more regional approach. So it's not necessarily in your community, but we have a conversation. What does accessibility mean for that family to have access to that level of service?
Mm-hmm.
But we're having those conversations driven by actual assessments that demonstrate the need. And that generally the experts in those fields agree these are the best instruments we have to determine, for example, when we're talking about level of placement. And so I think that's the standardization with the variation that I'm talking about. So you think about our trauma system. If I'm in a major traffic accident, I don't know, in Jordan Valley, I'll just pick the southeasternmost part of our state, you go from triaging there to what is the trauma response? Is it available in my region? If it's not, we have a clear system to get you to the trauma response you need. We just don't have that in behavioral health. That's where I think we need to go. We need to start thinking about that with the understanding that behavioral health is different, right? That what we bring to bear are different types of services, but they're the services that are necessary to treat our underlying conditions so that we either don't reach crisis or we get out of crisis quickly and on a path to wellness. And I think that's the other part of parity that we often don't talk about, which is making sure we have access to services and treatments for the duration necessary. And the type of conditions we have will need longer duration and engagement than what you often see on the medical surgical side.
We see that a lot in the work that we talk about with treatment courts, fits to proceed, even civil commitment, that someone is in all these services and all these supports and they're doing really well. And then the program ends, they're technically not part of that anymore. And then all those services and supports end.
Right.
And then it's finding those all over again. And the frustration in that, because now everyone is shocked when someone doesn't do well again, how would you expect them not to do well again when we took these services and supports in order to support them, and then we took them away because they weren't part of the program anymore? So that figuring out a way for a continuation to be available for folks, so it isn't this on again, off again episodic piece, but a continuation of support is what I
Well,
think
and I
about
think
when you
that's,
said.
again, that gets us to that question of standardization.
Mhm.
How is it that one system providing this can say this is what this person needs, and yet another system, once they leave this program, can say they don't qualify for that or we don't have that? In behavioral health, we allow such a high degree of variation. We allow proprietary criteria and proprietary level of placement evaluations. There's such a lack of uniformity and standardization that you can conceivably see a payer or somebody arguing they don't qualify for that. And there's nowhere we can run to say, yes, they do, because we allow all these different systems to use different criteria, different instruments, different everything. And it really, the frontier for us, the next big step for behavioral health has to be around standardization and uniformity. And again, I don't say that to be interpreted that something in Frontier, Oregon has to be identical to Portland Metro, Oregon. We don't even have that in medical surgical, but we do have uniformity of what you can find in Frontier. What do you do when you can't find it versus what do you have in a metropolitan area with just a broader treatment infrastructure?
I'm really glad you're saying that, because I think sometimes people hear conformity and guidelines and they think, oh my gosh, they're going to make it so everything has to be like it is in the Metro core or down the I-5 corridor, and that's not going to work in other parts of Oregon. So I'm really glad that you're taking the time to talk about how it's the guidelines support folks having services all over Oregon, regardless of where you are,
Right.
not that everything has to be exactly like it is in the Metro core.
I appreciate your comment, because when you use the term uniformity and standardization, particularly rural areas get scared because in the past, the state sets one set of rules and it's impossible. But again, I think that comes back to the lack of standardization. We don't have standardization of what things should look like in a frontier area, for example.
Yeah.
Most of the things that get studied are studied in environments and become evidence-based practices, and fidelity is based on a set of circumstances that don't match every geographic environment that you would find in a state like Oregon. And so that's, again, that next frontier is, what do these things look like? What is mobile crisis going to look like in a frontier area versus a metro area versus a rural area? And coming to a common set of expectations versus what we have now is just do it. But again, that comes back to, if you're not going to pay for these things, it's hard to have standardization, even with those varying degrees of hierarchy based on where you're at in Oregon, if in general, they're never going to pay for these things.
Yeah. It's hard to have standardization if you don't have placements and resources and you don't have staff.
Yeah, no. And what do placements look like? In Portland, they can look like this. In LeGrand, they may look like this, versus in Coos Bay, they're going to look like that. So yeah, you're right. Placements, thinking regionally versus thinking more provincially. There's a lot of good, rich conversation to have. And as an advocate, I sometimes get frustrated. As a former journalist, I realize why we're not there yet, because we've only just recently even cared enough to have parity. So we're 1 foot in the dark ages and 1 foot in the Enlightenment age, and we're straddling that line. And it's probably going to be for another generation to swing that foot out of the dark ages and be fully in the Enlightened age and be able to have some of these conversations, which frankly are not going to be easy conversations.
It seems like in Oregon, in the last couple decades or so, we've really started to do a lot of work in this area. And we've picked off the low, easy to reach fruit at this point, and we've made a lot of advances. But now we're starting to move into the conversations and getting up to the fruit higher in the tree that's harder to get to. We have to have more difficult conversations now to continue forward. It's not like the conversations we had a decade or two ago.
Think about it, a decade or two ago. So it wasn't until expansion of Medicaid we bothered to cover people. And among the people we covered were tens of thousands of adults living with serious mental illness who had no coverage at all. So it wasn't until 2005 in this state that we had any kind of requirement in most health insurance products. There had to be some level of parity. It wasn't until federal parity really took effect, I think, around 2012. The date's a little fuzzy, but there was a lag between when Congress passed parity requirements and when the rules were written.
Mm-hmm.
So this is a longer term conversation, and this may be a conversation that goes beyond my tenure, which is, where do we put the financial risk? Who do we hold accountable to this? And if we're going to do that, concurrently with that conversation is, what's the financing that we need to bring to bear? You can't have accountability without the financing. And a lot of times in the system, we try to have the accountability without the financing. And some part of that's understandable, because you have to think about it from our end of the stuff. Those of us who use the system, we want accountability. We need help. We need that help to be quality. And so our focus is a lot on accountability.
Well, and folks still need services, right? So even if they're not being backed financially like they should be, and the availability isn't there, folks still need services. But if the financing isn't there for their services, it makes the accountability really difficult.
Yeah.
Yes.
It's hard. It's hard to even have a conversation about ending many of the silos in our system without having where should the financial risk actually lie for whatever those functions are. There are things that are clearly healthcare functions. There are things that are clearly more public, more government functions. But right now, we don't even have a clear delineation of those things. And again, on the user side of things, the way that frustration comes out is on the accountability side, because it's harder to explain to people, this is a financing issue. This is a structural issue. That nuance is lost when your loved one, I'm just working with a family whose loved one has been in inpatient psychiatric care for over 250 days, waiting for a placement in a secure residential treatment facility. Mm-hmm. Had a placement, guy was willing to go. The provider decided, no, we don't want to take you anymore. So it was stuck in inpatient again. So by day 250, they got another placement at SRTF, but this guy doesn't want to go. He's done. Mm-hmm. He wants to get the hell out of that hospital. He said, I don't want it anymore. I don't want any more treatment. I don't want to deal with anybody else. You just put me in a hotel. I'm fine with that. We all know this guy's going to end up back in the ED. He's going to end up right back in inpatient. But we have this wacky system where we can't get people flowing through the system based on their medical necessity. We don't engage people when they're ready to be engaged. And yes, that's financing. On our side of things, what that is an accountability issue as well. So who is accountable for all this? And when people point fingers in multiple directions, we're not responsible, they're responsible. And you go over there and we're not responsible, they're responsible. That's how frustration bubbles up often from the NAMI perspective. And that's, I think, often where we get a reputation of being rather more of an irritant than a partner in some of these things.
I think you bring up a really great example, though. And it reminds me of the conversation I had with Kevin Fitz around folks being ready for something, asking for something, saying, I need help. Like the individual said, I'm ready. I want to go. I'm ready to go. And then it's not there. What we don't talk about on the policy level is what that does for the person that's living through this, what it's like to ask for help and then have it taken away, and then expecting that person to be like, oh yeah, now I'm ready again, when the system is ready for them, and how that is really problematic for expecting someone to be engaged. We need to be thinking about that human psychology piece of it around it being more person-centered and not just system-centered about when we're ready for you.
Yeah, that's a good point. But again, I would go back to this. You can't ask the system to do that systematically unless people are compensated in a manner that you bring the best out of people. I say this as someone who's been in the system. I say this as someone who has worked in the system. We get the quality of workforce we get because we're paying what we pay. And the quality, by and large, when you find someone who is good at what they're doing and they stay, it's often because of altruistic values more than anything else. And if you want a workforce to be receptive to people at the time that they're ready to receive and they're asking for help, and you're not paying that workforce to do that, then your workforce isn't systematically going to provide that level of service. And that's the conundrum we always are in, or the tension that we're in, is accountability and financing and how these things go together. And to date, we have always, I think as a state, and NAMI is just as guilty as anybody else on this, is we've approached it from an accountability side, and we really vastly underappreciated the financing side. But what this most recent crisis has laid bare, that whatever luxury we had to solve the financing side of things, we've lost that luxury. So we have to address the financing side. At the same time, we can't be out of balance, right? We can't just address the financing without holding the system better accountable. So if we're going to pay people more, then we better expect the things we expect from them, which is when I'm in the emergency room and I'm there for the 10th time because of substance use issues, that somebody actually asks me, hey, would you be interested in services? Sits down with me for 10 minutes and explains things to me instead of you're medically cleared, get out, knowing that we're going to see this person again.
It seems to me that there is the financing piece of the workforce being paid, and then there's the financing piece of placements for people to get services. Usually we talk about one or the other. And to me, when I think about this, I think about them going hand in hand. It's really important for someone to sit down and talk about options and be present and be great at what they do. But they're still doing it with a hand tied behind their back if there's nowhere for that person to go, even if they're ready to engage.
Yeah.
We really need to be talking about both sides of that
Well,
coin when we talk about
so
finance.
NAMI's contention is, and we say this to legislators all the time, is you have to do things concurrently. We have always done things in our system sequentially. So that's why we only have the state hospital rebuilt in Junction City and nothing else, because it was, we're going to do these things sequentially. You can't. That doesn't work that way. And so it was, what are you going to do concurrently? And what is a workable environment for one person is not going to be a workable environment for another person. So you need multiple environments. I get tired of this. We're constantly told the emergency room is not the place for us. Where is this magical other place we're going to want to go to? This is an emergency. We're not going to stop going to emergency rooms. So why aren't emergency rooms required to do better? And so it's, when we think about environments, again, we can't be monolithic in that response. You have to think about the total population. Remember, everybody has coverage now. So if someone is on their first trip to the emergency room versus someone on their 50th trip, the environments may be vastly different than what they need. It's thinking through all those things. The pitfall sometimes we fall into in the publicly funded system is people who have been churned through the system year after year. And how do we do better by that population, and never thinking about those people could have avoided being in that circumstance in the first place.
Right.
If, say, we had more access to programs like the Early Assessment Support Alliance or whatever that earlier intervention looks like. But it's hard to think that way. It's almost trying to think in 3 dimensions when we're used to thinking in terms of making change.
We need multiple things. Could you step back for just a moment for our listeners? Because not everyone may be familiar with ISSA. So could you give just a quick...
ISSA, it's a first episode psychosis program that is highly effective. So if I'm a young adult, you have a window there for most onset of psychosis, somewhere between 14 and 26. And if you introduce really intense services, the closer to onset you can get, the greater the likelihood is that you will not have a lifetime of disability and struggle, that we can actually keep you on a relatively normal life path. And so it's programs like that, and it's very effective. Oregon's been doing that for a long time, 30 years, variations of that. They just had a study nationally called RAISE, Recovery After Initial Episode of Psychosis, that demonstrated what we knew in Oregon. If you introduce services close to onset, you're very successful.
So you and I were talking about how you need multiple options. This is a very complex issue, and we're not going to solve it with just one intervention. So I'm curious around NAMI's thoughts around what's missing in the system. What do we need more of that we don't have now? And we know housing, we know placement, we know that type of thing for things that already exist. I'm curious if there are gaps that we haven't thought of. What haven't we thought of that we really need?
Well, what it looks like the particular program or environment, I don't know that I can go into too much detail about that, but we don't have urgent care in our system. What we're missing are points of engagement and being able to engage at these different points when we intersect with things. So it may be that I go to my primary care physician because I'm worried about something, and there's no real good response there. Usually it's a referral. Weeks. Right now, we're working with families that between their referral and first engagement, in particular for children, maybe months. And so when we first intersect, we don't have engagement. When we have a more urgent need outside of the emergency department, we have nowhere to go. You go to emergency departments, they'll look at you and tell you, we can't help you here. This is the wrong place for you. Or we have Unity, which is a place a lot of us would never want to be taken just because of the physical plant. Being in an open space when we're symptomatic is not a comfortable environment. When we're in school, what do you do in school? Onset happens when we're young. I'm somebody who had onset in high school, college years. What do you do there? So what we haven't really thought through are these points of intersection. And then what do you need off of there? And I think that's different too than some of the conversation that we have, which is around people who have ongoing chronic needs that cycle routinely. Again, with the understanding that some of those needs are cycling routinely because we didn't serve people very well. So we actually made them worse.
I think I heard two things. One, this piece around opportunity and engagement and having more of those and being thoughtful about that. But the other piece that I picked up on was within the opportunities for engagement, having places where people feel comfortable going for help. And I think sometimes that part, that's harder.
But I think it's harder because we let certain environments off the hook. And I'll harp on emergency departments because that's a level of frustration there. We're going to go to emergency departments, whether we've been through the system a million times or whether we're brand new because this is our first holy crap moment. And yet an emergency department, they get to say this is the wrong place for them. And we've never pushed back on that part of the system saying that you're supposed to accommodate crises. So I don't need to go somewhere else. You need to change. In addition to building some of these other environments like respite and those things that we know meet the specific needs of behavioral health conditions. But we also can't let these other environments. I got into it with an ambulance service because they were being asked to transport people in behavioral health crisis. And they put out a press release and got considerable coverage in the Oregonian because they wanted to complain about how violent people were. And so what their response was, we're going to train our workforce in self-defense. And I got after them. You're ambulance workers. This is a healthcare crisis. So I can understand some of that, but why isn't the thrust of it, you know what, we're going to train our EMTs better in de-escalation, about behavioral health crises, about all these kind of things, because they're going to encounter that. And why isn't it that they have to get better at that? Why is it that their solution is to learn self-defense so that they can defend themselves in the rare circumstance that someone might become violent versus actually better accommodating us? And as we think about the totality of the response, we also need these new environments, but we also can't let off the hook these other environments that are really part of the healthcare system and need to actually serve us. Those environments are independent of acuity. They're independent of how long I've been in the system. They're independent. Is this my first episode? Is this my 50th episode? Right? They're supposed to serve the population. They're supposed to serve the lifespan. They're supposed to serve us regardless of where we fall in terms of where we're at in our level of acuity and the trajectory of our condition. And we cannot let those environments off the hook.
It seems to me like there's two parts of that. The first for me is, what do those environments need in order to be properly trained and to be comfortable working with a population? What do they need that's different? Like when you were talking about the ambulance service, I could see why the response would be training defensive tactics, right? That's the initial response. The response that may be more helpful is training in de-escalation, training in behavioral health. So what truly meets the need for that environment in order to function better for the people that they're working with? What's the fear? What's the concern? How do we meet that concern in a way that's more productive for everybody? And then the second piece of that for me is, what does the environment need to look like so it serves folks differently than how it used to serve before, right? Because we have this old system and we talk about reinventing it, and we are, but we also have a system that's there and that we're going to have to tweak a little bit. So what does that system look like? How does it need to be different? How do people need to be trained to engage differently? And how is that system different in order to be able to engage folks differently? Is where my brain goes with that.
I think you hit on it. Yeah. It really comes down to, as the entity interacting with a person, how do you treat them in a customer-friendly way? And that's the training we're missing.
It's like the growing edge after parity starts. So if there's no parity before, and so you haven't served those folks before, but now you're being asked to serve those folks, but haven't received the training and the education and having to think about things differently. If you're used to heart attacks, car accidents, someone's cut themselves. That's what you're used to. And then suddenly this is a whole different way of being and interacting that has some things that are similar, but it's a very different presentation. That's a lot. So
Yeah.
how do we help folks in those environments be able to serve folks that are outside of their comfort zone?
I don't know that I can answer that question, but I know I can pick up the phone and bring people together and get people to confront that question.
Yeah.
And it's not like many people in these environments don't want that.
No.
Because they're asking for it,
Yes.
but nobody's there to respond to it. I do a lot of presentations and others do. So yeah, I think you hit on a question that I don't know that there's an answer to. I know we need what you're talking about. I don't know if we know how to fulfill it. And that's a question it's going to take smarter minds than I have to answer. Where NAMI is helpful is we will fight to see that happens.
Mm-hmm.
And if it means we got to go be an irritant in some environments, we'll do it. If it means we have to be friendly, we'll do it. And then we'll go fight for the funding to make it happen because we know that will benefit those of us who live with these things every day.
NAMI also is there for the education. So I know that NAMI has partnered quite a bit with crisis intervention team trainings and being a part of that. So not only the advocacy part, but I know that NAMI's been highly involved with the trainings for CIT and how phenomenal that has been and how that's been really life-changing for the participants in the training.
Yeah. And again, I may have said this earlier, that narrative experience that we bring as an organization and the multiple perspectives we bring as an organization really help people put in context what they're learning and why what they're learning is so important. And CIT is a great example. When I go to a CIT training, and this is not unique to me, I thank those officers and those first responders profusely, tell them God bless them for doing that, is that we don't want to have to call them. We know they're not intended to respond, but nevertheless, they have to. And we want that interaction to go not only for our family members, but we want them to go well for those responders as well. And so as much as we can be an agitator and be pretty loud, we also love to partner and have a lot of gratitude for whether it's CIT or whether it's physicians in training. I just presented to a couple of major employers here in Oregon because they know this pandemic has affected their entire workforce. So they're seeing issues across the workforce. The gratitude we have for all these environments having interest in this area. But you're right. It's that once you share that narrative, once you normalize something that is very normal, you do see more of an outpouring of understanding in this whole area.
Absolutely. And I think with NAMI, there's both sides of that. There's the advocacy piece and there's also the education piece. So you're saying, yes, this needs to happen. And hey, we're also here to help educate around this.
Yeah, we'll go anywhere. We'll do anything. Like I said, we have the world's worst business model. We'll do it for free, even for institutions that could probably pay us a lot of money to do it. And I will say the joy of being part of a NAMI again, isn't the advocacy side. It's the necessary side. And there's joy in getting part of a coalition to get a bill passed or a budget out. But the greatest joy I have is talking to a workforce. It's teaching. I can teach a class we have called NAMI Basics, which is for parents and caregivers raising school-age children to have something going on, don't have to be diagnosed. I can teach that class because I am a parent who has raised a child who had onset by age 13. So I can bring my training and my lived experience and work with other parents through this 6-week class and know that I may not be answering all of this family's questions or getting them always to the right places, but I'm helping. I'm helping parents not feel alone. I'm equipping parents with information. I'm hopefully getting them one more step down what's probably going to be a long road to getting really suitable help for their family. But it's those type of interactions those are the 14,000 Oregonians we help every year. And that's primarily, as I said, through our 15 chapters that are all across the state. People often ask, the other thing they ask about is like, how does NAMI, why do we advocate for what we advocate for? We have 15 chapters across the state. We're all volunteer, except for a small number of us who draw compensation. We're all volunteers. We're in constant dialogue, not only with our volunteers, but with the people who come to NAMI across the state. So we know we are part of conversations in Coos Bay. We're part of conversations in Ontario. We're part of conversations in Klamath Falls. We're part of conversations in Portland. So you name the community, we're there. And so it's that amalgamation of information and perspective is why we advocate for the things we do. It's not as if we're picking things out of the ether. It's based on what people are coming forward with and experiencing. And that's a nice position to be in as a membership organization, to be able to really be an accurate voice of what not only people are experiencing, but an accurate voice of what people need.
Chris, if someone was watching their loved one and they think there might be something going on, I was listening to this and thinking about when you were talking about that with kids, that they don't necessarily have to be formally diagnosed. You just think that there's something going on. I think folks, they're so scared about what's going on and they don't think about who they can call. So I'm really glad that you talked about that. How would folks get a hold of NAMI if they wanted to reach out in that way?
It's pretty simple. You just call us at 503-230-8009, and we will connect you as best we can to the resources in your community. One of the benefits, an unexpected benefit of going through a pandemic, is that all our programs went online. So now it's not dependent on a physical entity to, here's a support group in your community you have to go. You can get online and you can network with other parents. You can network with other people living with mental health disorders. We have parent groups. We now have about 40 support groups a month that we offer online. So call us. One of the more reassuring things I get to say to families when they call, regardless of what part of that family they are, is, look, the story you're telling me, I know you feel alone. This is probably the third time today I've heard this story. Yeah. So you're not. And then you connect people into a community, and that community has therapeutic value. So I came to NAMI through advocacy. And why I stayed with NAMI is I was just sitting around a table one day. It was at their annual conference. I wasn't even a volunteer yet. I was just kind of someone on the periphery. And I was sitting out at the registration table, and a couple other people who live with mental health disorders were talking about their experiences. And it was, again, a holy crap moment. It's, really? You go through that? I thought it was just me deficient. I felt like a bad person because of these thoughts I was having and these experiences I was having. Day after day, I am blessed to be able to talk to people to get them through that moment that, hey, you're not alone. And hey, this isn't going to be easy. And I don't know that I have any great answers for you, but I'm going to give you a few answers to try. If that doesn't work out, you keep coming back to us. It's going to be a long journey, but hopefully we can help get you there.
And for our listeners, we'll make sure to have the phone number and the website in our show notes, so you don't have to go back and listen and play the phone number over and over again to get all the digits. We'll have that in the show notes that you can just click to, and you can click right to the website as well. Chris, the website for the NAMI Oregon chapter is?
NAMI OR, so for the abbreviation for Oregon, NAMIOR.org. We answer emails too. A lot of people are uncomfortable phoning. We don't phone a lot these days, and we're working on getting text and all that other stuff. But phone and email are our primary modes of communication. And on our website, you can look and see if we have a local chapter in your community, and you may be more comfortable reaching out to someone in your own city or region.
So in the time that we have left, Chris, I'm wondering if there's anything that we haven't talked about that you want to talk about, or any last thoughts for our listeners?
I always try to remind myself of where we started from, where we're at, and where we're going, because I think it's easy to lose hope in this system. What we need to do is so huge. Sometimes it's hard to figure out where to start. And I like to constantly remind myself of how much we've actually achieved as a state since just when I started with NAMI, which was back in 2004, fighting for parity in the 2005 legislature. And NAMI often, again, we're agitators, we're complainers, we're loud, we're vociferous, and there's a reason for that. But as we talked about earlier, we're also good partners, we're hopeful, we want to help. And that combination of things keeps me hopeful for the future, that we can keep momentum going forward, because we can't afford to slide backward. And so far we haven't. And it may be frustrating, the pace of change, for those of us who are really impatient. But what is encouraging is, in our state, it's not as if we're not moving forward because there's some segment of our population that is nefarious and doesn't want to change. It's because we're still grappling with these really hard questions of, what does that look like? How do we get there? And so I guess I would close with this, is that as good as a complainer as I am, and I get paid to be a pretty good complainer, I'm also really hopeful that in a state like Oregon, that is a very progressive state in terms of thinking about health overall, that we have still plenty of opportunity before us to really make dramatic change.
I think that's a great way to end it. And Chris, I'm right there with you. I recognize all the change that we've made in Oregon. And when I talk to folks nationally, how far we are ahead of some places. And yet I feel the frustration too around change and how slow it can be and how sometimes it's hard to hold on hope.
Well, it's hard when you have another national organization telling you Oregon's 49th in the nation in mental health. And the reason we're 49th is because we have higher than average prevalence. No other reason. So we're not 49th. We're a state that expanded Medicaid. We're a state that has put significant amount of money into our behavioral health system. We're a state that is actually doing things. And so if we hang our hat on that ranking, will look like there is no hope. But that ranking is a fallacy. It's because we have higher prevalence. And that in itself is a problem we need to confront, but it's not a reason to lose hope that we're some terrible state doing a terrible job.
I'm so glad you talked about that. So when you say we have higher prevalence, do you mean because we have so many people enrolled and getting help and that's why? Or is it because we tend to have more people in Oregon with a behavioral health condition, or we just happen to know about more people?
It comes through the National Health Survey, that annual or every other year survey where people fill out if you had a mood disorder, if you had this or that. So it's all based on that. And based on that survey, we have a higher percentage of Oregonians who say they've had a mental health condition. And that's higher than the national average. So why that is, we don't know. So what factors should we address that would address those circumstances? But in the way that those rankings are weighted, that has a higher proportion in those rankings than, say, access, where we're middle of the road in terms of access. And so I chafe against that 49th ranking because it's some construction based on that survey, and we get penalized pretty heavily because of, in that survey, we have a higher prevalence of Oregonians responding, yeah, I got something going on, versus the national average.
And it could be that we talk about it in Oregon, we don't talk about it in other states.
It could be, you just don't know. The survey doesn't get down into what were the causes. It doesn't give you really helpful information in terms of how do you address this? Why does Oregon have higher prevalence than, say, some other state? We don't know. We don't know the factors. In the ranking, we get penalized pretty heavily. And that's why, again, I chafe against when people come out and say, we've done all this work and we're still 49th. No, we're not actually 49th. And the reason we're not really 49th is because we've done all this work. So if you look at it differently, we're one of close to 30 states. That means there's 20 states that haven't expanded Medicaid. Our legislature has actually put more money into our publicly funded system, where some states have cut funding for their publicly funded system. So if you go by what I would think are the metrics that really count, we're not 49th. Nevertheless, that doesn't mean we're doing great. Right? We can't sit there and rest on our laurels because we haven't done anything wonderful than not be worse than somebody else.
Right.
But I always look at that when people say we're 49th, is, you know what, we've done a lot in this state. We have a lot of good people trying to do the best they can. 49th is inaccurate. And so let's not lose hope because somebody out there says we're 49th because we happen to have higher prevalence than the national average. Again, that's where I have hope. We live in a state where we have the opportunity to continue to make change, to put money in. These are hard conversations. They don't always go the way I want them to go, which is frustrating. Right. Nevertheless, it's not as if opportunity has closed down, and we have a good track record as a state of continuing to try to push forward.
I agree. I see that even in the fitness to proceed work that we do. There's things that Oregon does that other states have just started doing, but we've been doing for a while. Not all restoration occurs in the hospitals. Community restoration, while it needs more resources and needs more placements and it's not perfect, is at least available and happening in Oregon. And also restoration is not allowed in jail in Oregon. And that is a piece that in some states, restoration happens in jail. And jail is not a place to restore folks to competency.
No.
So there's some great policy things that happen in Oregon that aren't happening in other places.
And I think you bring up a great example of also the challenges we have, which is it's on the criminal justice side and the judiciary side that some of the more provocative conversations are occurring for no other reason than it's been thrust upon that system to try to solve something that isn't their problem to solve. So it's both something really exciting. It's like, look at our justice system doing all this great work. And it's also frustrating because it's like, why are they having to do that work? Why aren't we doing this on that? But yes, I think that's a good illustration of how opportunity in Oregon. We try to capitalize on it, but it's also a good example of where maybe we're missing the boat a little bit here because we're not addressing this as a matter of healthcare as well.
Mm-hmm. Welcome to my world, Chris.
Yeah, when they talk about the intersection of behavioral health and the criminal justice system, I'm thinking, why the hell are we always focusing on that intersection? Why isn't it the intersection of when that person first hit the healthcare system and preventing them from ever getting to the criminal justice system?
You know what I love, though, and because I'm, as you know, always in these conversations about that intersection of behavioral health and criminal justice. But what I love is now, because there's been so much movement in this intersection, that is brought up quite often.
Yeah.
How can we get folks before they come to us?
Right.
What makes sense before they come to us? Yes, we absolutely want to make sure that folks are getting services in the intersection, but how do we get there where people are never in this intersection, and how do we invest differently? And I'm really excited to see more and more the movement towards prevention versus reaction for when somebody's already in a system.
It's not even true prevention. What is intervention?
Yes.
So, it's we present someplace and we do the right thing then. And so we think of it as prevention because what we're trying to prevent is the intersection with criminal justice system.
Right.
And what we want is a healthcare intervention. And once we have the right interventions, then we can really talk about real prevention, which is preventing people from presenting with a need in the first place.
Excellent point, Chris. Yeah. Excellent point. Absolutely. I've been so enjoying my conversation with you. Anything else that we wanted to talk about?
No, I think I've droned on long enough. It's nice to be able to think in the clouds a little bit. Day to day seems, especially now, seems like such a grind because people really are suffering because what we're going through applies across our population, regardless of whether you were going to have a behavioral health disorder or not. It's our entire state, country, and I will say, and you guys see this too, the work is getting harder and there's a real challenge in front of us. But once in a while, it's really good to get up in the clouds and think. So this has been a nice opportunity.
Thank you so much for joining me, Chris. I have loved having us together on committees, being able to hear your point of view and being able to work with you in that regard. But this has been great to be able to just sit down one-on-one and think in the clouds for a little bit. It's been great. Thank you for joining me today.
Yeah, you're most welcome.
The Center Collaborative is a production of the Oregon Center on Behavioral Health and Justice Integration, a specialized division of Greater Oregon Behavioral Health Incorporated. It is produced by me, Chris Thomas, with production assistance from Patrick Kennedy. Music by Patrick Mulvihill and Patrick Kennedy. Subscribe to the Center Perspective using your favorite app. To learn more about criminal justice and behavioral health in Oregon, visit the Center's website at ocbhji.org. You can also find us on Facebook. We'd love to hear from you. Please reach out to us. Join us next time as we chat with the experts about programs and partnerships at work within this complex and yet compelling field.